Hello everybody and welcome again to the Tissue Viability Program. So today we're going to talk about the patient-centered approach. There's quite a few wound bed preparation paradigms out there. We're going to talk mostly today about the DIME. There's others like it, very similar, but can also be different. But at the end of the day, what we're talking about is that systematic approach that will take in consideration that the patient should be the center of our care. So what is DIME? So it's an easy framework. It started off around 20 plus years ago. You can see names attached to it like Gary Sibbald from Canada, Rob Schneider from the US. Basically what they were talking about is trying to give us a template on whenever we are meeting a patient with a chronic wound, but it can also be used on acute wounds, is how can we use a systematic approach which will give us better results and obviously will lead us to use those pathways that we've talked about previously that can give us a better understanding on handling of our patients. So the practical clinical guideline, what does it talk about? It has 7 steps that we will go through together, hopefully making it easier for you to understand how you can implement it. The first step, we've talked about this previously during the assessment especially, is understanding what type of wound we have. And as we said previously, knowledge and expertise is needed here. And if we do not have that expertise, if we do not have that knowledge, this is where we need to find other people to assist us with their expertise. For example, if we are not sure of what we're looking at, and we will talk about this during, for example, the leg ulcers session, is to refer to people, because if we get the etiology incorrectly, then definitely our treatment will not be proper. So that comprehensive wound assessment is important. We've talked about all the steps that we need to do in assessing the wound, making sure that we are not just looking at the wound, but looking at it in a holistic manner, the whole, not the whole, and understanding also if there are any cofactors, comorbidities, which will impede healing. Only after we've done that assessment, as we said in the previous session, can we embark on identifying the best practice guidelines. Hopefully these best practice guidelines will be part of our protocols and internal guidelines that will lead us to manage these patients as effectively and efficiently as possible. The next thing that we talked about previously as well, but it is a huge issue, is understanding where our patients are coming from, understanding all the issues that are concerning our patients, their families, and their carers. The environmental assessment that we hinted to about last time, understanding what are these constraints, but also like having that discussion with the patient of what is the biggest concern regarding their wound. Things would be obvious, like, will this wound heal? Will this lead to an amputation? What about my pain? What about my exudate? So having that open discussion with the patient, doing that consultation that we talked about in the previous session, is really important. And rather than preaching, don't do this, do that, it's creating that rapport, that therapeutic relationship with our patients, because only then we will be empowering them, their family, and their carers to make sure that we are providing the best care possible. It's a partnership, and in order for it to be a partnership, we need to create these therapeutic relationships with them. Another very important thing to remember is that, unfortunately, not all wounds are healable. So when we look at the factors, cofactors, etc., what is in the wound that will not just only make that wound difficult to heal, but in some cases, it will make it impossible. For example, if we have irreversible ischemia, there's no way how to provide circulation to that lower limb. Non-modifiable underlying cofactors, for example, age, but also diseases, for example, malignancy. What is the medical status of the patient? Also, the size of the wound. Is it too huge? And we will see in a few minutes also that it's not only healing or non-healing, but also we will talk about maintenance wounds. So all these factors we need to consider. How are they interfering with healing? Can they be modified enough to allow healing? And can they also ideally be corrected so we get away from those problems and start the wound healing trajectory? So healable wounds are those wounds that we know that they are well supported both by the anatomy and physiology, pathophysiologies, but also by the patient's will to help us. But there are wounds which we call maintenance wounds. So this is where there are a lot of issues that cannot be elevated totally. There are issues where you know that the patient makes some choices. Maybe not because they don't want to create that rapport with us, but it cannot be modified. For example, if the patient's job is interfering with wound healing, we're not going to tell him to let go of his job. Talking about compression, for example, what are the issues there? Then there are so many examples that we can give that when we are giving a protocol to our patients, it cannot be elevated totally. Are the resources there? You guys are very lucky to have all the resources available, but we know, for example, in third world countries where they don't have any resources at all, but it's not only third world countries. Think about a patient from Australia, for example, who lives in the middle of the outback, and the next clinic which is closest to them is maybe 3.5, 4 hours drive away for them. So we need to make this whole assessment to understand if that wound is non-healable, where we have these non-modifiable risk factors, that irreversible ischemia, advanced age. Unfortunately, we don't have the fountain of youth. If you find it, please let me know. Irreversible malignancies, and all those issues that cannot be modified, which means that we cannot heal that wound. So what is the difference between a maintenance wound and a non-healable wound? So a maintenance wound does have the potential to heal. If we collaborate with the patient, look at the systematic factors that can be mitigated, it can lead to wound healing, which can give us still some problems. Think about the issues that can be modified. So you have a wound which is ischemic now, then we do an angioplasty and an angiogram, get the blood flowing again, making sure that that wound has become healable now. So look at all these issues that we have been talking about. Lifestyle choices that we mentioned even last time that cannot be modified. So this is why that assessment that we talked about in the previous session is so important, because it sets in your mind what is the pathway that we're going to take, what are the objectives that we have for our wound. So once we have eliminated these barriers, we have put the client back into the healing pathway. But as we said, this is not always the possibility, because if you have these non-modifiable issues, lower limb edema, pressure, you cannot turn the patient, you have systematic diseases that cannot be eliminated, medications that are needed for other diseases in the bodies, etc., etc. So again, make sure that you do your groundwork. If you don't plan, you're planning for disaster. So making that initial assessment is imperative. If you don't set off on the right foot, then we're going to have problems. So if you look at the risk factors with hard to heal wounds, there's loads of them, depending on the patient, depending on diseases, systematic factors, psychosocial, etc., etc., etc. All chronic wounds are hard to heal, but once we use the paradigm of the wound bed preparation, it makes it a lot easier for us. So your first step, is it a healable wound? Is it a maintenance wound? Is it a maintenance wound that can be converted to a healable wound? Or is it a non-healable wound that basically we don't have any chance of healing that wound? So what do? We give up? The answer to that is no. But we cannot use the proper paradigm shift here. So treating the cause is out of the question. We cannot treat it. We have found out that we can only modify some factors, make them a bit better, but at the end of the day, healing is not possible. The quality of life here is your main concern, alleviating that pain, the odor, all the issues that come with these palliative wounds, as we'll see. If you're doing debridement, only surface debridement, don't go deep, because you can make the wound worse. It's very important to still manage infection, prevention, and treatment if it is there. Moisture changes. We don't keep the wound very moist, and the wound will not epithelialize, so using the advanced wound care products will not make any difference, and we will basically be throwing away resources. So the practical approaches here, we focus on the plan of care, as we said in the beginning. So healable wounds, our main objective is to heal the wound as quickly as possible, prevent or manage infection if it's there, and in the long run prevent recurrence by means of continuously compressing the lower limbs, offloading, etc., etc. In a non-healable wound, we only use symptom management, as we'll see in the next coming slides. Debridement, one is regular debridement, taking away everything that we can. On the other is just conservative, moisture balance, as we said. One we keep it moist, the other keep it on the dry side without desiccating it. If it is infection, definitely we need to use all the ability to manage that infection, both locally and, if necessary, systematic. So when we are looking at non-healable wounds, instead of using the acronym of DIME or TIME, whatever we use the acronym of HOPES that was brought to us by Kevin Wu, which means that we are taking it in a totally different way. So the first part of HOPES is H, which is the hemorrhage. We make sure that we are managing this type of wound very, very gently. These wounds can be very fragile. They bleed very easy. Many of the times they have hypergranulating tissue. The important thing is here is to use non-adherent dressings. Don't use those paraffin gauzes. Use dressings that you make sure that will not dry out, that you can remove very, very easily. If you have a patient that has been referred to you and they have these greasy gauzes or other type of dressings that will adhere, make sure that you soak them before you remove to make sure that you will not going to traumatize that wound. If you need to debride, very gentle debridement, just removing the top. You can have advocation of hemostatic agents which are available there, and sometimes we even refer to the lab to see if there are any deficiencies which might not be totally correctable, but can be maybe alleviated. So the dressings that we use here is maybe alginates, but remember that alginates can stick to the wound. So if you are using some type of alginates or hydrofibers, make sure that you flush them away very, very gently. The non-adherent dressings here are probably your safest bet, because you can use non-adherent dressings which are neutral, or non-adherent dressings which are also with an antimicrobial, which can be very easily removed without traumatizing the wound and causing that hemorrhage again. Odor control, you know, it's quite important for these patients. Some of these wounds, especially if you have ever managed a fungating wound, you realize how nasty that smell is. We need to make sure that we control the odor, because this will elevate some of that social isolation for our patients. These are usually, the smell is usually caused by anaerobic bacterial burden, but other gram negatives as well. So for us, what we need to do is making sure that we make the management looking at using exudate management if it's exudating a lot, and always using that gentle wound hygiene. There are dressings that you can use. You can use an occlusive dressing, but it is not highly recommended, because especially if you have anaerobic microorganisms and you close all the gaseous exchange within the wound, you will be having more problems. Activated charcoal dressings work as a filter. You can use topical antimicrobials like metronidazole, which has been used for many, many years. Remember, here using a cream is not an issue, because we are not going to heal the wound. So it is symptom management. Topical antimicrobials will also help if you have high level of microbial burden in the wound bed. The chief concern is pain. These wounds can be very painful, as you are aware, so making sure that we can refer the patients to the pain experts in our facilities, but also understanding that the pain can be caused by the dressing. So again, using those non-adherent dressings, which will not need very frequent dressing changes. Some of these dressings can be left in place even for up to a whole week, but obviously depends on the status of the wound. Some of these wounds are very itchy because of that nerve irritation, that dermatitis, etc. But especially the peri-wound skin, we need to make sure that we are protecting it, making sure that we are using moisturizers if the skin is very dry. Use of cooling agents. I know of some colleagues that use these hydrogel dressings that can cool the wound down, so it alleviates a bit that pruritus, but sometimes even the pain. If you are in doubt, also please refer to your dermatologists. That can help you quite a bit here. Exudate management is obvious. There are dressings out there nowadays that will help you retain that exudate, these super absorbent dressings, but choose a dressing that either incorporates, or else you have to add a non-adherent layers. There are other types of dressings which can also gently debride the wound for you without causing any trauma. So basically here you might be achieving quite a few things if you use these type of dressings. You have the absorption by the fibers, you have the non-adherent layer, you have the antimicrobial, but you have those cleaning fibers that will keep the slough on the wound to a minimum. Superficial local infection, we need to always manage it. You have to talk about your protocol, see if it is always suggested to use antimicrobial as prophylaxis here. Again, whatever you're doing, make sure that you're using non-adherent antimicrobials. If you're using any creams or ointments, for example, the metronidazole, make sure that you flush it away properly. Do not try to remove it by means of using, for example, a gauze. Always be as gentle as possible with these wounds. There's another nice mnemonic if we're looking at non-healable wounds, which is comfort. So C is for care of pain and itching. using odor control, managing exudate and bleeding, fight infection, optimize the peri-wound skin integrity, use reparative and aesthetic wound dressings, and treat the cancer as much as possible. But remember, these palliative wounds is not just cancerous wound. We got those non-healable wounds, for example, with irreversible ischemia, that will still fall in this type of management. So this management, we call it palliative, not because it is a cancer wound only, but also when we are dealing with non-healable wounds of other causes. So if we are looking at a healable wound, what are we going to do? So we start with the systematic approach. We start with the first thing that you do, which is cleaning up the wound. So if you use maybe the TIME acronym rather than the DIME acronym, basically it's semantics, tissue, debridement, same. So the first thing is to understand debridement. When we're talking about debridement, it is the initial, very important part of the wound, because without that maintenance, debridement and the sloughing, cleansing the wound, clearing all the debris from the wound, we cannot get the wound to move on to the proliferative phases. So remember that debridement is not just inside the wound. We will see when we do the DFU that even the peri-wound sometimes needs to be debrided. We mentioned epibolia as well in the previous session, so that needs to be debrided as well. But the debridement will also allow the wound to drain, to help optimize the preparation of the wound bed and stimulate the wound towards healing. Debridement and cleansing of the wound is also necessary before you take any type of sample from the wound. So if we have to look at a definition, and sorry for reading from the slide here, but this is a very precise definition. So according to the European Wound Management Association, and there's other definitions, but they are quite similar. So it is the act of removing necrotic material, eschar, the vitalized tissue, serocrusts, infected tissue, hyperkeratosis, slough, pus, hematomas, foreign body, debris, bone debridement, or other type of bioburden from the wound, with the objective to promote wound healing, and does not only refers to the removal of bioburden from the wound, but also the liberation of wound edges as well as of the peri-wound skin. I know it's a mouthful, but it's very meaningful, because it tells us that we need to clear everything which is not supposed to be in the wound by the most effective way possible, as early as possible, not just to reduce the microorganisms in the wound, but also to get the wound edges to have the facility to migrate and start closing that wound once the wound is filled with granulation. So by removing all of this, we don't just start the wound towards healing, but we are making sure that we have reduced the exudate levels. We are starting to reduce all the problems like marauder and getting the risk of infection even lower. So basically, you are stimulating healing, you are stimulating epithelialization. At the end of the day, what you are doing is making sure that the health-related quality of life of your patient is a lot better. So remember that when we have debridement, we are looking at healable wounds. So in these healable wounds, we try to remove as much as possible, sometimes quite aggressively as well. When we're talking about non-healable wounds, remember what we talked about before, that we do just surface gentle debridement, maybe by means of dressings, which are very gentle to remove these contaminants. Another thing that we have to look at is the issue of selectivity. So what is selectivity? When we are removing any of the things that we talked about in the definition, it means that we are trying to select the non-viable tissue and remove it as quickly as possible without damaging the healthy granulating tissue. Non-selective management of debridement means that you are removing the necrotic tissue, but also disrupting the living viable tissue, which can be painful for the patient, but also create problems because we are regressing back to the first stages of wound healing. So selectivity is another thing that we have to consider. So just to refresh, what are the targets? What do we mean by debridement? Is removing all the huge list that we talked about when we were looking at the definition, decreasing the odor, the moisture, the risk of infection, sorry for the typo there, stimulating the granulation and epithelialization, improving the microcirculation of the wound and the quality of life. So we will, we will refer to this also when we are talking about exudate management, and we already referred to this in the previous session. One of the first things that we start doing, which is sometimes unfortunate, is treating symptoms rather than the cause. So when we have a wound which is highly exudating, we use those super absorbent dressings, basically putting the bucket under a leaking tap rather than managing the tap itself. The tap in this case would be the bioburden, would be the debris in the wound, and we have seen from many publications. For example, there was a very big observational study from Germany where they started using these polyacrylic fibers with silver to remove, clean the wound, basically debride the wound. And what they saw was that very quickly the exudate levels started going down, and the results were that because they were treating the symptom by means of wicking it up, but also managing the cause by means of removal, that burden on the wound bed, the exudate levels started reducing very quickly. So the deep removal of these non-viable tissue, the removal of all the material which is in there. Try to think, for example, if you have a patient that comes into the ER after a road traffic accident, they might have grit and asphalt from the road itself, or glass if we're talking about an industrial. So basically what we need to do is we need to clear there, because we are doing an exercise where we are preparing the wound, but also looking at the wound edges. For example, are there any epiboli, hyperkeratosis, management of the peri-wound skin. Maceration leads to dead cells, so looking at the wound and around it as well. What we are saying here is that debridement is not a revision of the wound. That is something totally different. That's a surgical procedure. It is not the resection of healthy tissue, and debridement obviously has got nothing to do with amputations. Remember that when we have ischemia, it is unsafe to debride that necrotic tissue. We need to make sure that there is enough circulation, that if we are debriding that wound, we have enough support that the wound will not become necrotic again, but starts the trajectory towards healing. The main types of debridement are listed here for you. You will go through them one by one, but the decision protocol, how are we going to decide what type of debridement we need to do? Especially, obviously, if you're talking to surgeons, they will tell you that surgical or sharp debridement is the easiest and best way how to achieve it, but it is not always possible. For example, if you don't have somebody who is licensed to do it, or it's a very, very painful wound, you will not be able to do that. So looking at our targets, and you might even notice that at the end where you have mechanical, there's a lot of question marks there. It's because things have changed. And we will see like why some things which were not considered as quite good a few years ago have been modified now are a lot safer. So what do we need to take in consideration? We need to look at ourselves, we need to look at the patients, and we need to look at the wound itself. Do we have enough skills and training, resources? Are we abiding to our protocols, and what is the cost involved? If we're looking at the patient, what's happening with the patient? Is he in a lot of pain? What are his choices or her choices? Do we have also comorbidities or, for example, ischemia that we cannot do the debridement effectively? But also looking at the wound, what is the wound telling us? Do we need to remove the necrotic tissue as quickly as possible? Or can we take some time using, for example, autolytic debridement? What is the bioburden in that wound? Do we need to clear infection? Is there biofilm in there? Etc. So again, doing a focused assessment, making sure that we are not just looking at the wound only, but also looking at ourselves and looking at the patients themselves.
Debridement is the removal of necrotic tissue, foreign material, and debris from the wound bed. Debridement enhances wound healing by reducing the wound bioburden, improving the ability to fight infection, shortening the inflammatory phase of wound healing, decreasing the energy required for wound healing, and removing physical barriers to wound healing. Clinicians may choose from one or a combination of debridement methods, including sharp, autolytic, enzymatic, and mechanical debridement. In some instances, the clinician may request a consult for surgical debridement. When determining the most effective means of debridement, the clinician must consider the characteristics of the wound, the status of the patient, current state laws, existing practice acts, and his or her own skills.
Sorry for the quality of the audio on that video, but I think it gave you quite a good idea about what we're going to talk about. So the first type of debridement is mechanical debridement, which up to a few years ago we used to shun away from because it meant using wet to dry dressings, basically putting in a gauze dressing in the wound, let it dry out, and then just yank it out. Makes you remember maybe of really painful procedures for our patients. Those should never be used. It is not recommended at all because it is totally non-selective and totally painful for the patients. However, nowadays we have different methodologies. We're going to talk, for example, later on about hydrotherapy, but also thinking about newer type of dressings that will allow us to do mechanical, gentle debridement. Again, look at the evidence. What is it telling us? Is the evidence for this type of mechanical debridement preferential for us, for our patient, and the wound? So don't say mechanical debridement is bad. In the old days it was, but nowadays with new generations of dressings it has become quite a viable option for us to use. Autolytic debridement is quite commonly used, especially when we are looking at community healthcare, because many of the nurses will not have the license to do surgical debridement. But the use of autolytic debridement is many times used before we do other types of debridement. If we want to soften the fibrinous tissue or the necrotic tissue inside the wound, then we can prepare the wound. Always remember to check, especially if you're using hydrocolloid dressings, that you test for anaerobic microorganisms, because these will definitely be happy if you close all the gaseous exchange for them, but also especially if you're using these types of hydrogels, that you protect very well the peri-wound skin. Remember that hydrogels are mostly water, so they can easily cause maceration to the peri-wound area. So it is again another option for you. Think about the speed that you want to use, think about the status of the wound, and understand if autolysis will be the way to go forward for you. As we said, sharp and surgical debridement is one of the most common methodologies used. You need to have somebody which is licensed, so depends also on the dexterity of the person doing the debridement, if it's good or not. The difference between sharp and surgical, sometimes we see them as two different things. So sharp is many times considered as bedside or in the outpatient's clinic, where surgical debridement is where we take the patient to the OR and we can go deeper. Again, if we're talking about sharp debridements, there are a lot of tools that can be used. It is not just a scalpel. You can even use things like curettes, etc., that will remove the debris by means of using tools. So in my opinion, when we're talking about sharp debridement, we don't just talk about using a scalpel, but using all the different types of tools that we have, that we can remove the debris from the wound, making sure that the procedure is not going to be too painful for the patient. If so, probably we need to refer to a surgical debridement where we anesthetize either the whole patient or part of the patient so that we can avoid pain for our patients. Hydrosurgery is picking up quite a bit. This is the methodology where we use a stream of water, and then we have a vacuum to remove whatever we are taking off the wound. These are quite good if the person using it has been trained properly. Can be quite expensive because it's not just buying the machine. You need to buy the bits that use, can be quite expensive. You need to have specialized training as well. There are constraints. Maybe people say there's a lot of vapor spray around, but using obviously shields. But also nowadays there are ways and means that you can use, and the technology has gone forward quite a bit. Another interesting type of debridement is ultrasound assisted. We've seen quite a few publications about this, where they apply low frequency that will debride the wound without heating up the wound too much. Quite simple to use. You still need a bit of training, but again, it requires this specialized equipment that can be quite expensive. One type of debridement that has been used for many years, but obviously nowadays has been quite refined, is by using the larvae of the green bottlefly, which we bring from a lab. It's not the ones that are flying around. They are quite good because they will only remove necrotic tissue. They are 100% selective, quite fast, but you need to convince the patient that you're going to put in worms in his foot or his leg, which is not always very easy. They come up with questions: will I see flies flying away? Which obviously is not, because it's only for 3 days. Will I feel them eating? No, because they don't eat. They secrete this enzyme and then they basically siphon it up. So again, a lot of convincing for the patients. It's not very easy to do it sometimes, but once you apply it the first time, they will see the rapid improvement. So the application of maggot therapy is quite a specialist type of wound care that we do, and although it doesn't need a lot of training, but it does need some training. So the first thing we do is we trace the edges of the wound, because then we can cut what we call a window for the wound, where you use these thick hydrocolloid dressings to fenestrate the wound. So you are protecting the peri-wound skin, because these can be quite wet. You cut also the netting, then you put a little bit of saline on the maggots. The maggots will then you put them on the net, and you apply the net directly on the wound without the need of pushing it down. Remember, these guys will grow up, so you have to leave quite a bit space. You use absorptive dressings, they can produce quite a bit of exudate. You can remove them after 3 days. You can change the outer dressing every day if you want. Nowadays, they are also available in biobags. Obviously, it is quite more easy to apply. It is also sometimes easier for the patient to accept. Remember, always using those high paddings, and you can change the padding every day, but you usually keep the maggots on the wound for about 3 days, and you will probably need more than one application to make sure that you are clearing out all the debris. Remember that these will not just remove the slough or the necrotic tissue, they will also remove the biofilms and all the debris inside the wound. So very, very effective, but not available everywhere, unfortunately. Enzymatic debridement is something which I am not a very big fan of, because you are putting on a cream or an ointment in the wound. Patients many times complain of pain. Remember that pain is an alarm. But these are already available, quite cheap to use, used quite a bit also in the community, like autolytic debridement. Always make sure that you are protecting the peri-wound skin. Obviously, they are contraindicated in ischemic ulcer. Remember that you are using whatever type it is, it's still always a chemical, and basically that is why I'm not a huge fan of. The other discussion that has been happening these past few years is, listen, we're not just talking about eschar here, we are talking about slough as well. So should we actually differentiate? And if we look at what slough is, and we've already talked a bit about this, slough is part of the inflammatory process of a chronic wound. It's basically a breeding source for all the microorganisms. It is one of the biggest precursors of biofilm, so it is important to remove the slough from chronic wounds. And that is why now there are discussions, and there have been quite a few publications about it as well. Should we start differentiating debridement from the sloughing? We're talking about debridement of eschar, and we're talking about the sloughing. Some people agree, some people don't agree, because basically their concern is that, but aren't we using the same approaches? Not all the time. For example, if you remember when we were talking about mechanical debridement and the new types of dressings, these dressings will remove slough, but they cannot remove eschar. So basically what we're talking about here is, look at the type of wound you have, look at the resources that you have, and you make a decision there. However, there are treatment pathways out there looking at the different types of slough which is there, looking at using flushing methodologies to remove, using surface and dressings that cleanse, autolytic mechanical desloughing, etc., etc. So again, comes down to assessment, again comes down to making a decision on what will work better for the wound, for the patient, and for us. The other discussion is wound cleansing, and according to newer publications, wound cleansing should not be considered as a type of debridement. However, cleansing the wound is a very important part of our preparation of the wound. So we can use different types of cleansers to remove all the debris which is on the wound. So as you see from the definition, it can be quite similar to debridement or desloughing, although it is not suggested to be part of. But the therapeutic cleansing is very, very important. Again, discussing how aggressive should I be on the wound. Depends on whom you talk to, but obviously looking at if it's painful for the patient, trying not to traumatize the wound and trying not to traumatize the patient as well. So it's very important to use good cleansing techniques to clean the wound as much as possible, always, obviously, before we take any type of wound sample, and also sometimes used to assist hydration of a desiccated wound. However, because it's a short period, it is not going to make a huge difference here. One important thing is don't use cleaning or cleansing as a routine. For example, if you have a clean surgical wound, you don't need to clean it, you don't need to rub it, because basically, if you do that, you're actually going to traumatize that wound. Don't clean wounds unnecessarily. Which moves us to the next step. So we've done D, which is debridement, which is disloughing, taking care of that devitalized tissue. So the next step, once we've done that, is looking at two very important aspects, which is the chronic inflammation and the local infection. So if we're looking at the inflammatory process, we've seen the slide already. There's a lot of issues going here, and one of the most important issues that we have in the ongoing inflammatory process, as we discussed previously, is those very high levels of matrix metalloproteinases. So that is another thing that we need to take in consideration. If we have cleared the infection, we've debrided the wound, we need to use something, especially local therapy, that will start reducing these high levels of proteases. Remember that these dressings that reduce proteases don't just do that. What they're doing is they're putting the wound environment back into a healing trajectory, because once the MMP starts going down, then you have the upregulation of the tissue inhibitors of MMPs, but you start seeing the wound starting to heal as well. I don't totally agree with people who say we bring a chronic wound to an acute wound, because it's basically trying to compare oranges and apples. What we are doing is getting that chronic wound to the healing trajectory, getting that chronic wound to start healing again, because as we've seen before, a diabetic foot ulcer, a lower leg limb ulcer, for example, venous leg ulcers and pressure injuries, are chronic in their nature. So they will still remain chronic, but they are healing chronic wounds. Obviously, there will be people who don't agree with me. There's a lot of debate out there, but anyways, no need to go into dilemmas. So let's start looking at infection now. We've talked in the first session that the skin is there as a protective layer. Once that protective layer is gone, then we have a breach in the system, and we start getting microorganisms migrating in the wound. If we're looking at the microorganisms, we don't just look at the number, but also their virulence and how much they are able to multiply. And once that happens, what is happening in the wound, how it is creating that inflammatory process, which will not allow the wound to heal. So a very easy definition of infection is basically the multiplying microorganisms that will overwhelm the immune system. So it has breached the first line of defense, now taking over, and will not allow the wound to heal. So where does infection come from? Unfortunately, one of the most common ways how to infect the wound is by cross-contamination, by not using proper techniques. It doesn't need to be a total sterile technique. It can be a non-touch aseptic technique. Can also come from the surrounding skin and from endogenous sources. When you're doing the assessment of the potential for wound infection, this is where we think about even prophylactically managing wound infection, is again assessing the patient as a whole, all the comorbidities, medications, etc., etc., etc. So there are patients who might elicit the use of antimicrobials prophylactically. Again, there is a huge discussion about this. We're talking in the past few years about antimicrobial stewardship, basically making sure that we are using antimicrobials in a very judicious manner. But if we have these patients who are very susceptible to wound infection, then maybe we can get away with basically bandaging our head before we break it, managing the infection to make sure that the infection doesn't come in. If we look at the very interesting document that came out from the IWII, which I suggest that you go and download it. It's a very comprehensive document, the latest document that came out very recently, is looking at all the aspects of the wound, holistically managing the wound infection for prevention, but also management. So first of all, we're looking at optimizing the response of the patient. How can we make the patient more in a position to fight infection, looking at all the environmental aspects that we talked about previously. If you have comorbidities, trying to optimize, for example, the levels of diabetes. Move on also to promoting the environment of the wound, but also making sure that we are reducing the microbial burden inside the wound. If you get that documented, it discusses in depth all these aspects. I do suggest that you read this very interesting and important document, which will give you a template on how to manage and prevent infection in your patients. So sometimes you are a bit confused on how to identify infection. How do I know if a wound is locally infected? There's quite a few tools out there, but one of the most recent ones, which I think is one of the easiest ones to use, is what is called the TILI score, the Therapeutic Index for Local Infection. So what they did here, and this is highly evidence-based because it doesn't have one, but 3 publications behind it. The first publication talked about how these group of experts came together. They looked at the classic signs and symptoms, that calor, tubor, rigor, etc., how to amalgamate it with other signs and symptoms. Then what they did is they compared clinical expertise to outcomes of the TILI score, and they found that it correlates quite a bit, and then they obviously published all the reports. So it's a very easy tool to use, and it's very easy to apply wherever you are working.
The TILI score, Therapeutic Index for Local Infection. Local wound infection caused by the multiplication of microorganisms in body tissues is one of the most frequent complications of healing. It can lead to pain, hospitalization, and death, therefore increasing costs for the healthcare system. Identifying local wound infection is difficult, and many clinical signs have already been described. European wound experts defined and published an easy-to-use clinical score for the early diagnosis of local wound infection and initiation of antimicrobial treatment. The TILI score, a therapeutic index for local infection. 6 indicative parameters have been identified. If at least 5 of these 6 indicative parameters are present, there is a local infection, and a local antimicrobial treatment is recommended. There are also 3 direct parameters. As soon as one of the 3 direct parameters is present, there is a local infection, and a local antimicrobial treatment is recommended. A practical tool has been developed to help you implement the TILI score. To use it, turn the wheel to the right and count the number of parameters present on the wound of your patient. Then find out what local treatment to apply on the back of the wheel. You can find all the information in the TILI score leaflet. Contact your Urgo Medical representative to obtain the tools.
So also, if you look at other publications, this is an older publication from the World Union, but it it encompasses the same ideas of the IWII, that when we're doing management of wound infection, it is not just looking at the wound itself. How can we optimize the host responses by managing comorbidities, risk factors, optimizing nutrition and hydration, managing to reduce the local bacterial load by preventing further contamination, making sure that we are using antimicrobials as needed and facilitating drainage. But also general management. Remember that infected wounds usually become very painful, and providing education and psychological and psychosocial support. And that re-evaluation, obviously, once the wound is changing, to make sure that what we have put in place is working. If not, what can we do better? The other thing, obviously, if we're talking about wound infection, is the question of microbiology. There's quite a few publications out there all throughout the years, which suggest to us and give us guidelines on when to use and when not to use these right types of microbiology investigations. This again comes from the IWII document, where they do give us a list of what they suggest where the investigations should be taken, when and where. It shouldn't be taken routinely. These are expensive type of investigations. Use them correctly only whenever it is suggested. Again, you can implement the IWII suggestions in your protocols and guidelines in your facility to make sure that we are not abusing of the system. There are different types of sampling that we can take. The older way of doing it was the zigzag methodology, where always cleanse the wound bed first and then rotate and zigzag the wound swab all over the wound, trying to avoid debris and pus. If we are taking samples from pus, for example, we have to tell the lab that this is a pus sample, not a wound sample. Always make sure that we are giving enough information to the lab to make sure that they understand what we are sending them and understand what we are expecting back. Tissue biopsies is considered as the gold standard. However, these are quite costly. Usually use tissue biopsies mostly to eliminate or confirm malignancy in the wound. If we are looking at evidence-based practice, the Levine or Levine, however you want to say it is considered as the best way how to take a wound swab. Again, you need to clean the wound, pre-moisten the wound if it's quite dry. Tell the patient, obviously, it's going to be a little bit uncomfortable because you need to rotate the swab tip in about 1 centimeter area and use that gentle pressure.
Next, we'll demonstrate obtaining a wound culture, and it's important to remember that the culture is not obtained until the wound is thoroughly irrigated, and we're only culturing good, viable, healthy tissue. So using the Levine technique, we're applying some pressure over a 1 centimeter area, and once we have our culture, we'll insert it into the culture tubing for sending to the lab.
Remember the importance of cleaning the wound for a couple of reasons. First of all, if you don't clean the wound, you can get a contaminated swab, which will not give you good results. And if you just take the wound swab of what is resting on top of the wound, these microorganisms, just by flushing, will go away, and they're not that important for us. What we need is understand what is living in the tissue, and that is why the Levine technique, because you're causing that little bit of pressure, is considered better. Now, looking at infection again from the IWII perspective, which is the IWI-WIC, which is the wound infection continuum, looking at the different stages of infection and what needs to be done. And we'll go through the different terminologies, but what is very important here is also the guidelines on what we are doing. So if we have a wound which is contaminated or colonized, we have to be vigilant, but we don't need to use any type of antimicrobials. Local infection is treated locally by means of a local antimicrobial. If we have spreading or systematic infection apart from the topical antimicrobial, we will also need systematic antimicrobials. So these are different types of algorithms that have been used. This is one of the suggestions. So looking at contamination and colonization, we clean the wound, debride if necessary. There's no need for antibiotic treatment or antimicrobials. In patients who are at high risk, sometimes antibiotics or antimicrobials are used. If we have infection, cleansing and debridement, surgically if needed, we need to use the local antimicrobials locally, but if it's systematic or spreading, we need to use the systematic antibiotics as well. So thinking about how should we intervene, that TILI score will help you quite a bit, because it will show you if it is locally infected, which means that you can use an antimicrobial dressing. And again, remember, there's a difference between acute and chronic wounds, and making sure that we are managing the wounds accordingly.
How do I know if I have a wound infection? Whether you're a patient, a nurse, or a physician, you're going to encounter patients that have had a cut, scrape, bruise, or other type of wound, and you need to assess quickly whether or not the wound is infected. So how do you know? What do you want to look for in your assessment? The first thing you want to look for is redness or erythema. If the area around the wound or the cut or scrape is heavily erythematous or red, probably the wound may be infected. Also, if the area around the wound is swollen, if there's a significant amount of swelling, you may suspect a wound infection. The other thing we tend to look at is if the patient is having a fever. Anybody exhibiting fevers along with a wound and you can't rule out any other causes, you're probably suspecting a wound infection. Drainage from wounds are very suspicious for wound infections, especially certain types of drainage. Clear drainage does not really indicate a wound infection. Clear drainage could be because you may be near a joint capsule or other things may be going on, or sometimes serous fluid coming out from chronic wounds. However, yellow, murky fluid will indicate possible bacterial infection of a wound. Green fluid that comes from a wound is usually indicative of Pseudomonas infection of a wound and should be treated differently than usual yellow drainage that's coming from a wound. Also, patients who have a wound infection will exhibit a lot of pain in the wound. It could be very sore, and they will need appropriate pain management. Also, think of foul odor. When wounds smell foul, patients, nurses, or physicians, when you're assessing a wound and it has a foul odor, most likely it can have an infection. There are multiple different levels of infection. You can have a localized infection that's just on top of the wound or on top of the skin, or you can get more active infections, and more active infections are when the bacteria or the infection gets into the patient's bloodstream and needs to be managed aggressively. Also, think about in patients who have wounds that are non-healing. If the wound just isn't healing, there may be an underlying wound infection exhibited in the wound that is causing the problems that's happening to the patient.
So another thing that we encounter when we're reading about wound infection, and is becoming more and more a center for discussion, is biofilms. And biofilms are unfortunately very common in chronic wounds. Actually, lately we have seen publications that biofilm can also be present in some acute wounds. What we have here is we have this another vicious cycle. We have those more microorganisms that aggregate to form a biofilm. Once that happens, we have degradation of the wound. They can have slough, but slough can also bring in biofilm. All will increase the exudate, etc. So what we need to do is make sure that we are trying to remove the biofilm. One of the challenges with biofilms, as we'll see, is that they reform quite quickly. Slough can be recurrent, and we need to do those serial debridements. And if we have slough, if we have biofilm, the levels of exudate will still remain high or even increase. So what we need to do is break the cycle. And we will see that sometimes using just those serial debridements might not be enough. So if we look at the biofilm cycle here, we don't need to go through all the details, but basically what is happening is you have these planktonic microorganisms that start attaching to the wound, start aggregating, and then they start covering themselves with a protective layer, which is the extrapolymeric substance, which protects them from the hosts, like the white blood cells, the macrophages, the proteases, but also protects them from antimicrobials or antibiotics. So once that happens, they start to mature and they start the cycle until they fill up most of the wound. So this is looking at it in a one shot. So basically looking at the cycle. So what we need to do here is not allow the wound to become full of biofilm. Stopping the biofilm from step one. We don't just wait for the biofilm to come back in again, but making sure we are taking measures not to allow the biofilm to form in the first place. That EPS, that gel-like substance that covers the wound, is basically a shield that cocoons all these microorganisms. There is a misconception that a biofilm can be visualized. This is not very common. Usually biofilms are not evident visually. Some of the signs and symptoms that there is a biofilm is the wound is not healing. Sometimes we take a swab, and if we don't take the swab, probably it comes back negative because the EPS is protecting those microorganisms, although there are different type of investigations which are quite specific and quite expensive, which can detect the biofilm. What is important to understand is that once we have the cocoon of the biofilm there, nothing can go forward. The host responses, the macrophages cannot go through it. They have all the process, the repeated inflammatory process going on and on and on. So if we don't eradicate that contamination from the wound, then you will not have migration of the proliferative phase and definitely not epithelialization. This is a very interesting study that was published quite a few years ago now, but it's still very, very nice to look at because they took slides to show that if you don't control the biofilm infection, you see that the migration of the epithelial cells will not happen. It gets stuck in the inflammatory phase. What big problem we are facing here? The big problem is that even if I'm doing the best type of debridement possible, many times I am not removing a biofilm. If you're using, for example, maggot therapy, if you're using aggressive surgical debridement, you might be getting rid of that biofilm. But in other ways, the problem here is if you're doing surfactant debridement, the EPS will start coming back within 6 to 12 hours. So what is the solution there? So looking again from the IWII publication, they have an algorithm about the step up and step down biofilm based wound care. So looking at the therapies that we need to use, making sure that we are looking at improvement. Once we see the improvement happening, then we continue to evaluate, making sure it doesn't go back. However, easily said, what we need to do is do the initial mechanical debridement, remove the biofilm, kill the bacteria or microorganisms by using an antimicrobial like silver, But what is very important is that remember that that biofilm can come back even within the few hours of 6 to 12 hours. So using a dressing that once you put it in will continuously clean the wound will not allow the biofilm to come back. Please be careful. There's a lot of dressings nowadays that have the tagline of anti-biofilm. Look at the evidence. There's not a lot of real anti-biofilm dressings. So making sure that when somebody tells you that we can provide you with an anti-biofilm dressing, look at the evidence and look what they are talking. Because some of the evidence about biofilm is that they look at it once mechanical debridement is done. Look at the evidence, evaluate it, and then decide if that is a real anti-biofilm dressing or not. So we've done D, we've done I, we move on to M, moisture balance. And the discussion about moisture balance started even before I was born. That tells you something. So in 1962, what the guy that is now considered as the grandfather of moist wound healing, George D. Winter, did a study on some animals. Basically, they did some wounds on these poor animals. They left some open, others they covered with a polyurethane film. And what they found out is that the healing in the wounds which were covered was a lot better, both in time, but also aesthetically. They didn't understand all the mechanisms about it, although they had already started learning a bit, but this came out later that once you have a moist environment, it is not just managing the lack of scab formation, because according to George Winter and according to what we know now, the epithelium does not need to burrow underneath the scab, but also that moist environment that stimulates fibroblast proliferation and synthesis of collagen. A year later, two other guys did a study now on human beings, and what was very important in the study is that they basically eradicated an old wives' tale. It used to be said, unfortunately, some people still say that if you have a moist environment, you're going to propagate microorganisms because microorganisms love a moist environment. But by means of having a moist environment, you are basically aiding the wound healing process, the macrophages and all the rest to come in and remove. So what they proved here, that actually infection is reduced, not propagated by a moist environment. The first initial impressions that were talked about when we have moist wound healing is that you eliminate a dry wound, so the epithelial cells do not need to go beneath to remove that scab. It promotes angiogenesis, promotes the cells like fibroblasts, and also promote the creation of the extracellular membrane. Remember what we talked about previously. If a wound is non-healing, then we need to think in a different way. So if we are looking at a non-healable wound, make sure that you do not over-moisten the wound, because then we can create more problems. But also, it doesn't mean drying up the wound, because if you dry up the wound totally, it can be painful for the patient as well.
Moist wound healing is the name given to the observation that a wound that is kept optimally moist will have better outcome than one that is allowed to dry out. Studies have shown that a moist wound heals between 3 and 5 times faster than a dry wound. The idea of moist wound healing was first defined during the 1960s. During this time, early preclinical and clinical research conducted by British pioneer George D. Winter first demonstrated the benefit of a moist environment in optimizing wound healing. The concept of moist wound care really took off in the late 70s and 80s, and an explosion in the number of innovative dressing products, such as alginates, hydrogels, and foam, was seen throughout the 1980s and early 90s. For the first time, dressings were starting to be considered an important and active part of the healing process. Our understanding of moist wound healing has come a long way since the days of the first research of Dr. Winter. We now understand why wound healing is promoted by a moist environment. This is due to several parallel processes. First, by preventing scab or crust formation over the wound bed, a moist wound environment eliminates the energy and time that would have been required for the body to break down these materials. Keratinocyte travel time and distance across the wound surface are also greatly reduced, as the cells are able to easily migrate across the moist wound bed rather than burrow underneath the wound bed to find a moist area upon which to move forward. A moist environment also traps enzymes within the wound bed, facilitating autolytic debridement. And finally, a moist wound environment preserves growth factors within the wound fluid and increases fibroblast proliferation and collagen synthesis. Before the days of moist wound healing, wound dressings were primarily used to protect the wound from secondary infection by forming a barrier against bacteria and absorbing wound fluid. With the greater understanding of moist wound healing came the imperative to develop newer and more innovative dressings that could actually help promote wound healing. Today's dressings fulfill all the functions of the earlier passive dressings, but also promote rapid healing, encourage vapor transmission, reduce pain, provide autolytic debridement, and act as a bacterial barrier. To learn more about moist wound healing and other key concepts in wound care, you may wish to consider becoming certified as a
So the moist balance, remember that we're talking about a moisture balance. So we're not talking about a wet wound. We are talking about looking at a balance where the wound is not too wet, but it's also not too dry, because only then can we achieve it. So how do I know that? That comes from experience, that comes from knowledge, but also looking at the dressing, looking at the peri-wound skin, like what we talked about when we were talking about assessment of exudate levels in the previous session. When we're talking about the last part, which is the edge effect, basically what we need to do here is to look at the wound if it is healing according to our plan and to our objectives. If it is not, what we need to do first is look back and make sure that we did the I and the M properly, making sure that the wound edges have been prepared to allow epithelialization. If that is not happening, then we need to look back, do again the assessments, but also maybe we can include some types of advanced therapies that can be considered. So in summary, what we talked about is looking at the cause, making sure that we eliminate all the modifiable factors, support the patients themselves both medically but also psychosocially, making sure that we are actively listening to the patient, managing the concerns of the patients, and empowering the patients with enough education and support. Determine healability. If it is not a healable wound, then we refer back to the HOPES acronym that we talked about previously. Tissue debridement, desloughing, cleansing the wound with non-toxic solutions is not considered as debridement, but it can help to prepare the wound, and then using appropriate techniques according to what is available, according to what knowledge and experience and licensing we have, and taking in consideration the wound status and the patient status. Manage and eradicate infection, thinking about biofilms, managing the stalled wounds, those inflammatory wounds, by reducing the biofilms, the MMPs, better managing of moisture. Always remember that you need to treat a cause, not a symptom. looking at if the wound is healing, thinking DIM before thinking about the E, and using adjunct therapies where indicated. So if we look at dressing selection according to the paradigm, what are we doing? The first one is the patient-centered concern. So one of the first things is remember that if you're healing the wound quicker, it obviously will make everybody happier. So you are treating everybody in the best way. You are producing healing outcomes. But remember, when it comes to concerns about the patient, yes, we are talking about prevention of malodor, prevention of exudate levels, but one of the main concerns is the pain. Remember to use proper dressings. Unfortunately, we still refer a lot to those greasy gauzes, but if you remember when we talked about George Winter, even in 1975, he produced a paper that we shouldn't be using these type of dressings because they can cause harm, not just only to the wound, but also to the wound healing outcomes. Looking at the debriding, there's a lot of dressings available out there which are indicated for debridement. Obviously, I'm sure you are aware of the autolytic debridement by means of alginates, hydrogels, and hydrocolloids, but also we've talked about MECID therapy, and we've talked about the newer methods of mechanical debridement using dressings which are quite safe. So there are types of dressings that we can see that have not just the mechanical debridement activity, but also will help to remove the slough from the wound and also have a non-adherent layer. So there's quite a few of these available out there, making sure that you are using a dressing which is backed up by evidence. Looking at infection, making sure that the dressing that we are using is a broad spectrum dressing, making sure that it has got enough evidence. And other types of dressings nowadays, even some dressings without an antimicrobial can help you do that. For example, we have these polyabsorbent fibers that can be either with silver or without, but even without an antimicrobial, this type of dressings, because they are constantly cleaning the wound, will reduce the bioburden. And if we're looking about inflammation, obviously the main culprits will be the matrix metalloproteinases, making sure that we are again using evidence-based practice-backed dressings, which we know will reduce effectively these MMPs. We're talking about moisture balance, either denoting, giving moisture or reducing the moisture. Remember, treating the cause is more important than the symptom, but initially we have to think about looking at if we've got the different types of dressings that will either provide moisture or remove the moisture. When we're talking about the etch effect, active therapies, for example, negative pressure, hyperbaric oxygen, or other types of active dressings, again, look at the evidence-based practice, look at what the international guidelines are suggesting to us, when to use, when not to use. For example, if you look at the suggestions by the IWGDF that we will discuss when we're talking about the diabetic foot, they don't only give us recommendations what to use, but they give us also recommendations when not to use certain modalities or dressings or devices. If we're looking at categories of dressings, the old type of dressings were these traditional dressings such as gauze or lint, which are basically were used as a plug and conceal, just using a cover. Basically, we see that this has been used since the times of the Mesopotamians, but they are not of very good use to us. Sometimes they may be used as a cheap alternative as a secondary dressings. Interactive dressings, on the other hand, the more advanced dressings where they are used to interact with the wound microenvironment. So we're not going through all the details, but just giving you a list of dressings which are available out there. So we have the alginates, which are made from derived from seaweed. They are used in moderately to heavily exuding wounds, they gellify, and therefore they can help us with debridement when needed. Obviously, we cannot use them in dry wounds, but also not suggested for third-degree burns or for surgical implantation. Antimicrobials, we can stay here and discuss for a very long time. What I suggest to you is check about antimicrobial stewardship. There's a lot of discussion out there. When you're using an antimicrobial, make sure that you are using it with care and not abusing it. Also, make sure that you are using safe antimicrobials. For example, there's a lot of literature about the safety of silver. Collagens, many different types of dressings out there. They're usually from animal, either from bovine, avian, porcine, nowadays even from fish. They can be used in some types of wounds that have been stalled. They can be quite expensive, so we have to use them meticulously. Contact layers, these non-adherent, make sure that you are using non-adherent layers, not low-adherent dressings that can be left in place. The two most common ones which are used nowadays are either the TLC technologies or the silicone. The difference is that the silicone is just a non-adherent layer, while the TLC layers can be used to promote healing as well. Foam dressings are basically dressings that we use to wick up the exudate. They don't do anything else. There are also categories of super absorbent today. Remember that yes, we can use foam dressings, but looking also at the cause, not just the symptom. Hydrofibers are quite common. They are similar to alginate dressings. They are used in moderate to heavy exuding wounds. Do not apply them to dry wounds, and they can also promote disloughing as well. Hydrocolloids have been used. There are different types of the thin hydrocolloids, thick hydrocolloids. There are also hydrocolloid pastes. They still have a bit of use, especially when we're looking at using them for autolytic debridement. And as we've seen, for example, when we're using maggot therapy, they're very good to protect the peri-wound skin. Hydrogels, hydrogels can come in amphoras, they can come in gels, they can come in sheets. They are used mostly for autolytic debridement, sometimes even used to cool down the wound. They provide a bit of respite for the patients. Make sure that you always protect the peri-wound skin. The polyabsorbent fiber are quite new on the market. These are non-woven hydrodisloughing wound dressings. They have quite a bit of evidence behind them. They can come either as neutral or with an antimicrobial. This is one of the categories of dressings that has been proven when it comes with silver that it is a very highly effective anti-biofilm dressing, because once you put it on the wound, it continues to clear it up and doesn't allow the biofilm to come back again. Another new type of dressing has been on the market now, I think, for about 10 years, is sucrose octosulfate dressing, or known as well as TLC and OSF. So this is a dressing that has got a lot of evidence behind it. One of the only dressings, if not the only dressings, that has double-blind studies behind it. So basically, sucrose octosulfate is highly recommended for use in venous leg ulcers, for use in diabetic foot ulcers, looking at using it on patients who are at risk of delayed healing. Transparent film dressings, again, can be used as protection, used also as fixators for cannulae and drains, sometimes used also as a skin protectant. Many are used also as either a secondary dressing or sometimes even a primary dressing, especially when you're looking at wounds healing by primary intention. So that is all for us for this session today. As I said in the previous session, if you have any comments or queries, please do let us know, and it will be our pleasure to get back to you with whatever reply you will need. Thank you very much, and see you next time.